Good morning, all of you. In this presentation, we will continue with the discussion about physiological changes. The cutaneous changes. The pigmentary changes mainly occurring in the face, breast, and abdomen. First, about the pigmentary changes occurring in the face. There will be pigmentation around the cheek, forehead, and around the eyes. This is known as pregnancy mask or cloasma gravidarum. These pigmentation may be patchy or it can be diffuse also. This will disappear spontaneously after delivery. Next is about the breast changes, which is already discussed in the previous session. Cutaneous changes occurring in the abdomen. Number 1 is linea nigra. This is a hormone-induced pigmentation. It is a brownish black pigmented dark line that runs from the umbilicus to the symphysis pubis and may extend as high as the sternum. After delivery, the line begins to fade. It may not disappear completely after the delivery. Striae gravidarum. This is otherwise known as stretch marks. This reflects a separation within underlying connective tissues of the skin. This occurs over the areas of maximal stretch, that is the abdomen, thighs and breast. It will change to white silvery lines few months after the delivery. In early weeks of pregnancy, the mother may have nausea and vomiting, so she may lose weight. After that, there will be progressive weight gain until the last 1 or 2 weeks. The total weight gain during a pregnancy can be 11 to 12 kg. During the first trimester, she may gain 1 kg and during second and third trimester 5 kg each. This is the weight gain occurring during pregnancy. This table explains the distribution of weight gain. Pregnancy is a state of hypervolemia. There will be retention of fluid in the maternal body. The amount of water retained at term is about 6.5 liters. The water content of the fetus, placenta and amniotic fluid is about 3.5 liters. During pregnancy, there is active retention of sodium, potassium and water. The important causes of sodium retention and volume overload are changes in maternal osmoregulation, increased level of estrogen and progesterone, increase in renin-angiotensin aldosterone system activity, increased aldosterone, etc. Hematological changes. Changes occurring in the blood volume. During pregnancy, the vascularity of the uterus is increased and the blood volume also increases. The blood volume increases progressively from 6 to 8 weeks gestation and reaches a maximum at approximately 32 to 34 weeks. The rate of blood volume increase varies according to the size of the woman, the number of pregnancies she has had, the number of infants she has delivered, and whether there is one or multiple fetuses. The increase is needed for extra blood flow to the uterus, extra metabolic needs of the fetus, and increased perfusion of other organs, especially the kidneys. Extra volume also compensate for maternal blood loss in the delivery. Changes occurring in the plasma volume. Plasma volume also starts to increase by 6 weeks. The rate of increase is almost same as the rate of increase of the blood volume. About 50% increase in plasma volume occurs, that is the total plasma volume increases up to 1.25 liters. Changes occurring in RBC and hemoglobin. There is an increase in RBC mass by 20 to 30%. The total increase in volume is about 350 ml. This increase is regulated by the increased demand of oxygen transport during pregnancy. Even though the total hemoglobin mass increases during pregnancy, there is a fall in hemoglobin concentration. This is due to the disproportionate increase in plasma and RBC volume. This produces a state of hemodilution during pregnancy. At term, there is a fall in HB level about 2% from the non-pregnant value, and this is called physiological anemia. Leukocytes and immune system. The action of polymorphonuclear leukocytes is reduced during second and third trimester. So, the chance to get infections is more. The total plasma protein level increases to 230 grams. The plasma protein concentration falls to 6%. This is due to the hemodilution. Blood coagulation factor also increases. The pregnancy is called as a hypercoagulable state. Plasma fibrinogen level also increases from the third month of pregnancy. Metabolic changes. All metabolic functions are increased during pregnancy to provide for the demands of the fetus, placenta, uterus as well as the mother. Protein metabolism. There is a positive nitrogenous balance is maintained throughout pregnancy. At term, additional 1000 grams of protein is added, that is fetus and placenta 500 gram, uterus and breast 500 gram, like that. Protein metabolism is enhanced to provide supply for maternal and fetal growth. Protein storage occurs and conversion of amino acid to urea is suppressed. So, the blood urea level falls during pregnancy. Carbohydrate metabolism. Transfer of increased amount of glucose from mother to the fetus is needed throughout pregnancy. So, insulin secretion is increased in response to glucose and amino acids. There is hyperplasia and hypertrophy of beta cells of pancreas, and the sensitivity of insulin receptors is decreased. Plasma insulin level is increased due to the effect of estrogen, progesterone, human placental lactogen, etc. And this mechanism ensures continuous supply of glucose to the fetus. Fat metabolism. An average of 3 to 4 kilograms of fat is stored during pregnancy. This is mostly stored in the abdominal wall, back, thighs, and limited amount is in the breast. Iron metabolism. Iron is absorbed in ferrous form from duodenum and jejunum, and it is released into the circulation as transferrin. About 10% of ingested iron is absorbed. Total iron requirement during pregnancy is about 1000 milligrams. This is distributed in fetus and placenta 300 milligrams, red cell mass around 400 milligrams, like that. And also there is usual loss of about 200 milligrams through normal routes. Other than this, there is a saving of around 300 milligrams of iron due to amenorrhea for 10 months. The iron needed during lactation is 1 milligram per day. In the second half of pregnancy, the daily requirement increases to the extent of about 6 to 7 milligrams. The amount of iron absorbed from the diet and that mobilized from the store are inadequate to meet the demand, even though there is absorption through the gut is enhanced during pregnancy. In the absence of iron supplementation, there is a drop in hemoglobin, serum iron and serum ferritin concentration at term pregnancy.